nice to meet all of you guys. My name's Namita Goyal. I am a neuromuscular physician. I've been treating myositis patients for over 12 years. I actually initially got very interested in myositis when I was at Mass General in Boston. Currently I'm at California. But I had a patient who was very early on in my career, was waiting for a muscle biopsy from a surgeon, was waiting for a diagnosis, and literally within weeks I saw her deteriorate, and I was really upset with our surgery team who didn't really understand the urgency of trying to get our patients diagnosed in the right time. And so that's sort of where my career started with myositis patients. Was I made a deal with them at Mass General that I would take care and do all the biopsies of all the patients with myositis if they would train me, and sort of provide almost same-day service for patients so that they would come see me in the clinic, and within a day we do their EMG and set them up, because I really believe in getting one, diagnosis soon and fast, and two, as many of you already know, sort of being in charge of your myositis and being empowered with the idea of taking care of yourself can be quite challenging because there are many elements to it. And so the Myositis Association just sort of asked me on how to talk about how to really be in charge of your myositis. Many of you may not be living close to an academic center or not. Can I just get a show of hands that some of you go to your local neurologist, or do you go to an academic center or a myositis center? So those for an academic center? Oh, okay. Okay.
Yeah,
and then it sounds like the rest of the crowd is local primarily? Okay. Yeah. So, yeah, and sometimes, that's not, that's also fair too, is we get some people that come from a distance just to get a sense and an opinion, and then if you have a good neurologist and if you understand what things to look for and what things to be in charge of, you can manage it quite easily locally sometimes, but it can be overwhelming. And so for me, this is a really informal session because I wanted to make it more about what questions you might have, but I thought I just created a few slides more on the outline of what you should be looking at as part of your care team. For me and my patients, I consider the most important people are either the neurologist or rheumatologist in charge. Not everyone, I do have some patients that see both, but I don't necessarily think you have to see both the rheumatologist and the neurologist unless there's completely different elements that you're looking for, because sometimes that can get a little confusing too if you have two similar specialists on board. A very good primary care physician, I have some patients that think that, oh, once they're seeing their neurologist, and since you seem to know everything, we'll just go to you and I don't really need my primary care doctor on board. But that's not true. A good internist should definitely be on board your care, and I'll go through each of these elements as to why I think they may or may not be important. The pulmonologist and cardiologist are elements that are add-on, I think, to your therapy, depending on the level of involvement. Not all patients. I think a cardiologist is actually more rarely involved, but there are situations where in dermatomyositis it can affect your heart. And so having them on board may be helpful. A speech swallow therapist, a physical therapist, a dietitian or nutritionist, if you're on several immune suppressants, can be helpful, and then a social worker. So feel free to interrupt me at any time, but I'm going to sort of show you what elements I think all of these people can contribute to your care. And sometimes you don't have to have every single one of these specialists on board, but as long as you're asking the right questions from your neurologist and your primary care physician, I think you can manage your care with some of these other specialists sort of as add-on if you may or may not need them. But a lot of patients ask me, you know, what should I be asking my local neurologist even? Like, am I getting the right care? And so I thought I'd give you a little bit of guidelines on some things that we think are very important when we initially see someone. So obviously number one, whenever I see anyone, even if they tell me I have a 15-year history of inclusion body myositis or dermatomyositis, I think it's really important when you see your specialist for the first time to take them through your story and your journey, have them examine your muscles. And then these are a few things that we find very helpful at our Myositis Center about the tests that should be done as part of your diagnosis. Blood tests, CK levels, antibodies, and I'm actually going to show you a few slides on antibodies. We now know that about 70% of patients with some form of myositis can have an autoantibody, and that gives us a little bit of clue of one, about their diagnosis, two, sometimes their prognosis and management. And I think you had a...
Yeah, with the antibodies thing, there was a panel. I had a myositis panel that I saw that, but there's been new antibodies coming out. So should they update that?
Yeah, I mean, I would say that if it's not been done in the last 5 years, for sure, and some are even more recent than that. Certainly if it's been done a year ago, I don't think there's a drastic change. But if it's been 3 to 5 years, I think it's certainly worth repeating. And as long as, and I put the caveat that if you feel like your disease is well managed and well treated, and an antibody has been identified, then you don't necessarily need to repeat it. But if an antibody has not been identified, it's a simple blood test. And unfortunately, I don't think many of the specialists that are out in the community may know about it. And so sometimes I like my patients educating, if my patients know something that I don't know or haven't heard of with a clinical trial even, I welcome that. And I think many physicians welcome you even saying, oh, there's a myositis panel, and it's just a blood test, could you send that for me? And I would say, on speaking behalf of many physicians, they welcome ideas like that, and you shouldn't at least feel that you're in a weird situation by asking for that. And I'll actually show you some of the slides. So in the room, has everyone at least had an antibody tested once, or panel tested? Is that no? So I'm seeing some potential no's.
Antibodies.
I'll show you some data, but it's a blood test that we are now helping us identify what type of myositis you have. And I'll show you why that's important on the next slide, just 1 second. We use an EMG or electrical study. It's not absolutely mandatory, but it's oftentimes one of the initial tests we do to confirm that a muscle disease is present. Many patients still have a muscle biopsy, and it is helpful to have tissue diagnosis to see how the muscle is involved. We also, as an add-on test, sometimes do a muscle MRI. There are some dermatomyositis patients that have mostly skin involvement, and they feel like their muscles are okay. And those patients, we're learning that if we do a muscle MRI, we may see subtle signs of muscle disease. It's certainly not a must-have, but as part of our clinical evaluation. It sometimes tells us about the severity of muscle disease there is, if the muscle is very inflamed, or if it's got a lot of end-stage muscle and there's a lot of atrophy instead. So the muscle MRI is giving us some insight into what the muscle is actually looking like. Yeah.
Will you cover the intervals that you should be retested on those same diagnostic?
Yeah, I'm going to cover the antibodies. I actually put, I do think it's very important for patients to have these, which is why I'm going to spend a few minutes on that. Thank you. And then for patients, especially with dermatomyositis, if you're over the age of 40, many of you know there can be a cancer affiliated with it. And this happens within oftentimes the first 3 years of symptoms, so you should be screened for it. And if your neurologist or rheumatologist hadn't, then it's at least a good idea to do malignancy screen once. I actually meet many patients that have never had this screen, and I do think it's important. So these are all the antibodies to date that they have seen, but I'm going to take each category in the next few slides. Dermatomyositis has a few antibodies, a few that are now associated with cancer in particular. The antisynthetase syndrome oftentimes previously was categorized as polymyositis, but we've now learned that there are several antibodies that are associated with this. The necrotizing autoimmune myositis has the statin antibody and the SRP antibody. And in inclusion body myositis, there's a range from about 30 to 70% of patients can have an antibody with this. And I'll show you, I sort of broke this down for you into why I think some of these antibodies are important. So there's now 5 antibodies that have been classified for dermatomyositis. And some antibodies actually, we know if you have this antibody present, like the Mi2 antibody, we know that you're going to respond fairly well to immunotherapy. So if I meet a patient with an Mi2 antibody, I generally start immunotherapy pretty fast. I'm aggressive with it. I also know, we now know that there's a low risk of cancer. However, if someone has a TIF1 gamma antibody and they have dermatomyositis, we've learned that there's actually a high risk of malignancy. And in those patients, if I see the TIF1 gamma antibody, one, I know that it's consistent with dermatomyositis, but 2, I actually repeat a screen for cancer every year up to 3 years. Because there have been a few cases of cancer that I've diagnosed, but they didn't even know they had it because their presenting symptoms were weakness and a rash.
My rheumatologist, I have him too, and he said, I had breast cancer, and he said, well, you've had your cancer now and you're done. Does it mean that I won't be getting any other kinds of cancers, or am I still susceptible?
Yeah, that's a great question. You still probably follow with an oncologist, is that right? And so you probably have like at least an annual screen.
Yeah, but she's just screening me for more breast cancer. She's not screening me for others.
Yeah, there isn't, from what I'm aware of, there isn't well-published data that once you've had one cancer, it's not like we've seen multiple other cancers following it. They think it's the cancer that sort of activated the autoimmune system to cause the dermatomyositis. So in your case, it was
12 years after.
I see. It was 12 years after the dermatomyositis. Yeah, and so you wonder, do you know, and it's okay if you don't want to answer this, but do you know if you had a screen initially when you were diagnosed with dermatomyositis?
They just felt for lumps.
I see. I see. So generally, when I see the TIF1 gamma antibody and the other one is the NXP2, dermatomyositis also has a risk of malignancy. Those are my two categories where, in addition to a routine screen, which is generally considered a CAT scan of your chest, abdomen, and pelvis, and a mammogram, if all of those are negative, I will even do a PET scan, which can pick up what we call occult or very hidden malignancies that are cancer-affiliated. So I wonder, you know, in someone that tells me that their cancer was diagnosed years later, if they didn't have a PET scan, or those people, you know, I would have probably had done a PET scan. But 12 years ago, we may not have had all this data on the antibodies, which is why I do think it's important for you as patients to know if you've had the antibodies checked. And then the SAE antibody also has a good prognosis. So this sort of, as you can tell as clinicians and patients, we care about which antibody we might have because it can sort of give us a little bit more insight into how you're going to respond to therapy or how you're going to do long term.
Can I ask you a question?
Yeah, absolutely.
Once you find one, does it make sense to look at others, or is it usually you have one?
That's a great question. And generally, if you find one antibody and it's consistent with your clinical picture, let's say you have the dermatomyositis antibody, the Mi2 antibody first, and you have a classic rash, you have some muscle weakness, then we're content with that. It's not like we say, oh, well, we should look for the inclusion body myositis antibody. However, if you haven't responded to therapy and you're not sure if your physician mentions, is this really dermatomyositis? I think it's okay to repeat the panel. I have repeated a myositis panel when I thought, is this consistent with the clinical picture or not? It seems like there's some mixed features. The patient's telling me maybe they're not responding well to immunotherapy. I always think it's okay to repeat it at least once.
You didn't go over the therapy process.
I'm sorry?
You didn't go over the therapy process.
Yeah, I'm gonna, I have a few slides on medications and what you should be looking for as a patient. These are a few of the antisynthetase antibodies. So if you have interstitial lung disease, if you have a lot of changes to your hands and arthritis, these are some of the common antibodies, with JO1 being the most common antibody, where we now know that 50% of these patients can have lung involvement. So if I see someone with the JO1 antibody, I tell myself, well, I definitely want to at least get a CAT scan of their chest and see what's going on there. So some people have this, some people have a myositis called an overlap myositis, and they may have other autoimmune diseases associated with it, like you can see here.
I think that's your Wi-Fi.
Is that what I need? Does anyone know the passcode?
CMA 25.
CMA 25. Let's try that. Thank you. Okay, maybe I should.
That'll put acid.
Oh, okay. Yeah, maybe that's why it is. Thank you. So there's several antibodies that, this is the list of them. These are more non-specific antibodies, but they can be seen in people with like Sjogren's, rheumatoid arthritis, lupus. So there are sometimes some people that will have an autoimmune condition and then have a myositis with it. these are the antibodies that we look for in these patients. Yeah.
What is, the second one, PM/SSC? I don't know what the SSC is.
Oh, okay. It's called systemic sclerosis, where some of these patients will have like a shiny appearance to their skin and their hands, have some swallowing problems, and that's why in those patients, if they have the PMSCL antibody, we check their lungs, we check their swallowing, because we know in those patients swallowing can become involved.
Is there anything for PM, IBM?
So we're going to talk about that in a second. There's two antibodies that are now associated. If someone tells you, oh, you have a necrotizing myositis, there's two antibodies that are associated. One is SRP, and the other one is HMGCR. The SRP antibodies tend to be associated with a very aggressive course of disease. Patients will develop weakness very rapidly. Their CK or muscle enzymes can often be in the thousands. Their neck in particular can get weak. And because these patients have a very rapid, aggressive disease, if I meet someone and I see that their SRP antibody is quite high, I'm pretty aggressive with treating them with medications like IVIG. If I have to, I even use a medication called rituximab. But the reason I mention that is because it's the antibody type that will tell me how aggressive I need to be up front. Because what we know, if you treat them aggressively up front first, they tend to do better. But if you sort of say, oh, let me just try a low dose of steroids, they may have a smoldering course. And as we all know, the longer that you have myositis that's not been well treated, the harder it sometimes gets to treat. Some of you may have, I'm sorry.
You start out with steroids first.
For the SRP patients, I actually often start with some steroids and IVIG, which is an immune globulin therapy. It's an IV infusion. And some of you may have heard of a statin-associated myositis. So what I want to mention about that is that we all take, majority of Americans have an elevated cholesterol and are placed on statins. And you don't have to worry about, not all cholesterol medications are bad, but in a very small population of patients, the statin medication can actually trigger myositis. And in those patients, it's really only 6 to 9% of all myositis cases. So it's a small population. But what we do know is that these patients tend to respond well to IVIG. And so oftentimes, as soon as I see that antibody, I don't waste my time with any other medication and I just start IVIG right away.
How effective is it?
How effective is it? It's actually very effective. I've just in this past year, I've had several patients, because we are a myositis center, we tend to see these cases that were undiagnosed. And I've had patients within 3 months have their CK go down from 8,000 down to hundreds, just because the IVIG treatment is that effective. And IVIG is a monthly treatment. So I thought I had the IBM slide in here, but the antibody for that, I'll go back, is the CN1A. And I think you were asking about that. It's also, another name for it is N as in Nancy, T as in Tom, 5, C1A. But it basically is the CN1A. And this antibody, a lot of patients are initially diagnosed with polymyositis. And for 5-10 years are placed on steroids, immunosuppressants, not responding, the weakness is not getting better. And the physician or the neurologist looks at you and says, I'm not sure why you're not responding. My rule is if someone is diagnosed with polymyositis and they've had it for 5 years and they've told me that they've been on 5 years of some form of immune treatment, I always check this antibody. Because what we're learning, this antibody was discovered in about 2011, I believe. And what we're learning is that many of these patients that were diagnosed with polymyositis actually have inclusion body myositis, and they just didn't have all the clinical features of it at the time of presentation, which is why people thought, oh, it's polymyositis.
So not everyone with IBM has this antibody, though, right?
That's correct.
Because I don't have my results back, but that's what they tested.
Yeah, so our group, our center at the California Irvine, we did a study on patients to see the percentage of time the IBM antibody was present in IBM population, and we had a range of about 65 to 70% of our IBM patients had it. However, and when the original publication was published, they had a similar percentage of about 60 to 70% of IBM patients may have this antibody. However, there's more recent publications that the range is even as low as 30%.
So when you say myositis panel, you're looking for lots of different myositis, but I was diagnosed with IBM, so my neurologist going after that one antibody.
Correct.
If I don't have that, do they need to check for maybe a necrotizing or?
So IBM patients, what's interesting about IBM is that it actually clinically looks very, especially later on in the condition, it can look very different than some of these other myositis patients. So most of these other categories, dermato, antisynthetase, the necrotizing, the weakness starts mostly in the proximal arms, the proximal leg muscles. But IBM has more of a unique phenotype where the distal hand muscles can be affected, and the quadriceps in particular have that weakness. And so if you have significant weakness, in particular in the finger flexors, or even the flexor compartment muscles can actually look thin, and the quadriceps muscles can look thin, that's a very particular clinical picture that we don't, our group also doesn't tend to fish for these other antibodies. However, if you just have proximal muscle weakness and you don't have the classic fingers involved or the classic quadricep atrophy, then we certainly start our fishing expedition where we will start sending the panel. And that's also, I'm glad you brought that point up, because the myositis panel tends to cover these antibodies. But if you have very high CK levels, like in the thousands, over 1,000, and these two antibodies haven't been checked, sometimes they're not part of the panel. And then the IBM antibody has not typically been part of the panel. It's a separate antibody that's tested. So you would have to request that. But there are now several commercial labs that do it, the panel testing.
Will they still be specific?
Yeah, you can't just say myositis panel and include this whole page.
Right.
If you're in these categories, that's all together.
Can you have both polymyositis and IBM?
So you're asking very controversial things. So there's more and more out on the literature that we don't believe there's actually truly polymyositis. As all of these antibodies, you know, every few years are being discovered, more and more antibodies, which is why I think it's pretty cool. I don't think I could say 5 years ago that 70% of myositis had antibodies, but now we can. And so what was not identified as the classic dermatomyositis patients, you know, if you had a rash and you had proximal muscle weakness, you had dermatomyositis. And if you had finger weakness and quadricep weakness, you had inclusion body myositis. And historically, everything in between was just grouped as polymyositis. What's also interesting is that it was in like 2011, 2012, I was asked to write a chapter for the medical school books on inclusion body myositis. Before then, inclusion body myositis wasn't even in the medical school books. And so I think it has been historically underdiagnosed and people were classified, but I think we're doing a much better job in more recent years in educating other physicians even on what is inclusion body myositis. But if you go to your primary care physician and you're out in, you know, some community area, your primary care physician may not have even heard of inclusion body myositis. And we're the ones that are having to educate them. And so that's why I did want to spend some time on these antibodies, because I think as being in charge of your care is knowing which one you have and how it may direct your care.
Over years of treatment, right, like with immunosuppressants and stuff, was that high testing for your antibodies?
No, apparently the antibodies generally still are present in urine. The CK levels may have dropped down. And certainly for inclusion body myositis, it doesn't change the status of your antibody. And I'm not sure there's great data on if someone that has a dermatomyositis antibody, if the antibody just goes away if you're well treated and well responded to. I'll have to look into that in more detail, but I don't know if there's been great historical data, like a 10-year follow-up on that or something.
Does a muscle, once you lose a muscle, it's gone forever?
It depends on what disease it is. For inclusion body myositis, I think that's pretty true that what we know with the muscle MRI, that's why I was mentioning the muscle MRI, is we've learned as a neurologist and rheumatologist taking care of these patients that when you do a muscle MRI in inclusion body myositis patients in particular, a lot of it is just replace the atrophy of the muscle is then replaced with fat. Like there's no more muscle in certain areas that are present. I think another important question to ask your physician is about your medications, right? So if you've been placed on a number of steroids or immune medications, it's important to know to sort of see them consistently. I like to see my patients every 3 to 4 months if I've had them on steroids or some immune medication. Because I want to make sure, one, they're responding. I believe that within 3 to 4 months you should see some degree of response by then. Do I need to adjust their medications? I also believe in never keeping someone on high-dose medications, especially if they don't need it. And so at least every 3 to 4 months, if they are doing well, seeing if I can taper down one of the steroids. We all know chronic steroids can cause a lot of harm.
At what point do you go on steroids?
So if there's dermatomyositis, if there's this antisynthetase syndrome, oftentimes we will place patients on steroids. And I do have a few slides at the end of
On the IBM?
talking about. But for inclusion body myositis, we actually don't give steroids. We don't give immune medications. There was a paper published a few years ago by the European group that actually looked at IBM patients and compared patients that were given some form of treatment versus no treatment at all. And this is just the inclusion body myositis group. But what we saw is that the patients that were treated with chronic steroids actually had a poorer outcome. And they tended to use more assistive devices, wheelchairs, walkers, versus the patients that have never been treated on immune suppressants. So, not that I want you guys worrying if you were or were not, but that gave me a lot of insight into, well, if I meet someone with inclusion body myositis and I'm very confident that they have IBM, I certainly am not going to do 60 milligrams of steroids because I may do more harm than good in the long run. And I think about people's current situation, their 1-year outcome, their 5-year outcome, their 10-year outcome, and so on. I think whichever one, if your primary care physician has, if you're getting referred to from a primary care physician and they say this rheumatologist is excellent, I think by mouth of word, I think that's fine. I think a rheumatologist or an experienced neurologist. Not all neurologists are experienced. Some neurologists tend to do more seizures and more, Parkinson's disease, and they may not understand myositis. The flip can happen too. So I think it's okay to interview your specialist too and know, do they understand myositis or not. But I think being able to sort of have some guidance on what are the right questions to ask them too. So if you've been on immunotherapy and you've never had any improvement in your strength, the questions to ask is, am I on the right medications? And then number 2, do I have the right diagnosis? Which is a really important one, which again brings me back to the testing and the antibodies. Anytime I meet anyone and they say, I've had a 10-year diagnosis of dermato, but I've never responded, I sit down and I say, hold on, let's figure out if you even have dermato. And I think the biggest flip happens with the polymyositis, inclusion body myositis patients, because many IBM patients were originally diagnosed with polymyositis. And this happens, because a lot of times they can mimic each other because patients will have muscle weakness, a high CK level, and then they have a muscle biopsy and it shows inflammation. Well, physicians have always been trained that, it sounds like polymyositis. But what we've now learned is that inclusion body myositis is actually the most common myositis over the age of 50. So common things being common, you want to think about that. And then just to briefly mention about the antibodies, you were mentioning that you've had the antibody tested for IBM and it was negative, or I don't know.
No, I don't have results back. They shipped it off to WashU. WashU to analyze it.
Okay. So we had, just a little bit about if you're positive or negative with the IBM antibody. We did a very small study. We were the first to do it of just 25 patients, and we looked at why they might be positive versus why they might be negative. And what we found is in IBM, if patients had the antibody, they tended to have more swallowing difficulty, a little bit more weakness than the patients that didn't have the antibody. Subsequently, after we presented that data, a European group did a much larger retrospective study, and they found similar findings. that if you had the antibody in IBM, you might have more disability. And if you didn't have the antibody, you may have less disability. This is a fairly new antibody, so we're still in the process of planning a larger study to figure out if those findings are true or not. So I don't want to alarm anyone, but I just wanted to give you some insight, because we're still trying to look at why people are positive or negative for that idea.
Are the doctors aware of that?
The people on the medical advisory board are aware of that, but I don't think every community neurologist is aware of it. And in fact, the Myositis Association had asked me to go to Denver to give talk to the myositis group there, and so I met with several myositis patients, and they told me that even though they were following at an academic center, they haven't had antibody testing. So I think we are trying to advocate more and more for it, just to make sure we have a better diagnosis, and we're taking the right treatment approach.
Wouldn't
So,
that help
and it's a
for
simple blood test.
other diseases as well? Like are they doing the same thing with antibodies?
You would think, right? That's what me and my colleague are really floored that, we think it's a simple blood test. It's not like we're asking for a genetic testing. So absolutely, I'm in total agreement. You would think. But, so we're trying to do our best to educate other doctors, but I think when it comes from patients too, I welcome it. I think patients oftentimes know much more than their physicians about these conditions.
Even where you're saying the primary movement, have you ever done
we haven't seen the classic DM patient transition. No. There does not seem to be any overlap with that. And then your primary care physician, I think, is a very important person. They don't have to understand myositis. But what you have to remember is just because you're seeing your neurologist or rheumatologist routinely doesn't mean your primary care doctor should go on the back burner. Just an annual exam, I think, is very important. Routine health issues come up, so don't forget about that.
How often?
Sorry.
How often?
Just once a year, if you're, at least to check it, to make sure that you have that established relationship.
Should they take CK levels and stuff again, or just leave it alone?
Yeah, we don't necessarily treat the CK. We're treating the patient. So the times
That's not a test they normally give you at a yearly. So my primary kept saying, "Are you drinking a bunch?" No. Well, he didn't know why the AST was elevated.
Yeah.
Well, it's a little high, you're a little above normal, and he said you're eating bad, you have fatty liver, or you're drinking. I said, well, I don't do either. So, but they don't really equate it with IBM until they find out, and now he's going, well, now I get it.
Right. And again, that's a great, I'm glad you brought up that point. That is so important. I can't believe that just doctors forget that AST and ALT, which are considered liver enzymes, are actually present in your muscle. So when you have a muscle problem and your CK level is high, your AST and ALT, which is that routine blood test that every primary care doctor does, is going to be elevated. Generally, if your CK level is in the hundreds, your AST and ALT are oftentimes elevated, and your primary care doctor might think, oh, this is a liver problem. Let's set you up for a liver ultrasound. I actually aborted 3 liver biopsies that were about to happen. I called up the primary care and I said, no, this is all muscle. So I've seen patients have liver biopsies for it. If they do want to make sure that the liver is not a problem, there is a simple blood enzyme test they can do that's specific to the liver but not present in muscle. So if you run into this situation where AST and ALT are elevated and your primary care doctor says, I want to start setting you up for all these liver tests, say, no, first can you just check my GGT? That's an enzyme that's present in your blood that will reflect. If your liver is normal, even if your AST and ALT are 450, your GGT will be totally normal. So yeah, it is important to let them know you have myositis. The other time it becomes really important is if you are placed on steroids and you're having a problem with controlling your blood sugars, more routine follow-up than just once a year is actually very important. Your blood sugars can go up, your blood pressure can go up. Don't forget, people always forget that even low-dose steroids, as soon as you're placed on them, start eating at your bones. Steroids are wonderful medication in treating myositis when they work, but they have ugly side effects. And I always tell my patients, at least start with some vitamin D, like 2,000 units, and supplement it with calcium. Some of the over-the-counter have come with D with calcium. Calcium helps increase the absorption of vitamin D. But a year later, you should have a bone density test if you're on steroids. And then the other thing that's really important is that if you're on immune suppressive medication, and you're not feeling well, something just seems off. You know, you've been doing great and you've been stable on stuff, but since a week ago, you're just not feeling well. You can get sick, and because you're on immune suppression, you may not mount a fever or have the typical symptoms that show signs of an infection. Infections can happen in the blood, so just a simple checkup with your primary care doctor. They'll check your blood, make sure there's not an infection. A pneumonia, swallowing issues happen in myositis, and you can aspirate and have a pneumonia. So that's why it's important to have a good primary care doctor. Vaccinations, I get this question a lot. Vaccinations are okay for patients, but you just want to avoid a live vaccine if you're on immune suppression. But we definitely recommend the flu shot and all of that annually. And then I think also another very important thing to remember is that anyone with any medical condition, it can be hard. And I think it's totally okay to sometimes need a little bit help with an antidepressant if you're having a hard time dealing with it, just psychologically. It's difficult. Medical conditions can be difficult, and I think it's important to remember that and ask your primary care doctor. They may not ask you, but it's okay to check.
With the antidepressant, shouldn't maybe proceed with psychologist?
It really depends. It depends on the level that you need help. I do have that on some of my later slides, that psychologists, psychotherapists, support groups, all of that I think can be really helpful. Some patients do or don't want to deal with that. Some patients just need a little bit boost in mood, and so an antidepressant is okay. I think there's a lot of stigmata people have and say, I don't need an antidepressant. I'm a man, I can deal with this, you know, but I think it's okay.
That may be a problem.
Right. So I guess I tend to talk a lot because as you can tell, I like myositis and I want to make sure everyone has good care. But some other people to have on board, or at least once checked annually. In our clinic, we have a respiratory therapist, and we at least do pulmonary function tests to make sure the breathing, the lung is okay. The diaphragm is a muscle that gets weak. That helps so if you have respiratory insufficiency, a lot of our patients use BiPAP at nighttime. It happens often in IBM patients. Sometimes if you've had it for 15, 20 years, many patients may need BiPAP at nighttime. So at least having your pulmonary function test once a year, at least I think is helpful. And if you don't have someone in your clinic that checks the breathing numbers, your primary care doctor can refer you to have a pulmonary function test. You don't have to have a pulmonologist. The time that's really important is for the patients with dermatomyositis or antisynthetase syndrome when they have lung disease present. Then we generally have a pulmonologist on board. A cardiologist is rarely involved in myositis, but is needed when the heart becomes, remember the heart is a muscle. In IBM patients, we don't see a cardiomyopathy or a cardiac arrhythmia. If it is, it's incidental or age-related, generally not related to the muscle disease. But in dermatomyositis or antisynthetase syndrome, you can see that the heart can sometimes be involved. And so these patients should have a close relationship with the cardiologist. But if you have IBM in general, besides the routine yearly screening, like age-related, I don't think you need a cardiologist. In our clinic, we also have a speech-swallow therapist. Swallowing can become an issue in the dermatomyositis patients, antisynthetase syndrome. In IBM, what we know is up to 1/3 of patients may have some form of swallowing difficulty, and it can sometimes even just be pills feel stuck. A barium swallow, that's what this picture is here, can actually show what is happening in the esophagus and if your food is going down the right or the wrong tube. It will actually tell you if it's going down the wrong tube and you didn't even know it, and you're having signs of an aspiration pneumonia that can develop. So it is important for people that report swallowing issues to at least have a barium swallow done once to get a baseline evaluation. And there are some patients, this is a rare complication, but it can happen where the swallowing muscles become so involved that they need a G-tube or a little feeding tube, which what's good to know about it is that it's really helpful in preventing food from going down the wrong tube. If you're choking and coughing with every meal and you're not even getting adequate calories in, it's a great way to reduce the chances of having aspiration pneumonia. And this is extremely rare, but some patients can have speech difficulty to the point where communication becomes harder. Sometimes this happens in the very advanced cases of IBM, but it's pretty rare. But there are some really unique communication devices that you can use nowadays that are attached to wheelchairs, and you can press buttons and have preset phrases. A physical therapist, I think, is one of the most important people in all of our myositis patients. If you need adaptive equipment, they help screen for braces, for canes, for wheelchairs. They can counsel you. We believe all myositis patients should start some form of exercise. And so having a trained specialist see you, if you're on immunotherapy, if you're not, what we know is exercise in general is good. Exercising to the point of severe muscle pain is bad. So the no pain, no gain motto does not apply in muscle disease. It can actually cause exacerbation or acceleration. Heavy weightlifting, the goal isn't to become bodybuilders, but it's just stretching, range of motion. Stationary cycling, I think, is a great form of exercise. If you don't do anything, even just a stationary bike, and 15 minutes 3 times a week can be a great starting point, and then building up on that. In California, we tell them if it's safe to get into a pool, Pool therapy is a great form of exercise because it eliminates gravity. Our physical therapist is trained in doing a home safety evaluation. If you do have significant disability, like getting up from the toilet, getting into showers are hard, there are physical therapists that are trained to evaluate your home to see if they're safe, and they can give you recommendations on where to put in bars and what showers might look really unsafe, and getting you a shower chair if that's what's needed. So I think that's a very helpful point. And then we all know nutrition serves a role in our muscle disease. And so some of the challenges are if you're on steroids, weight can become a problem. Steroids are a wonderful, I call them one of the best drugs for dermatomyositis and antisynthetase syndrome, but it's one of the ugliest drugs. It comes with, it's hard on your bones, it's hard on your blood sugars. You can develop sort of a moon face from the weight gain. And then if you have a problem with it, nutritionists are very good about helping you count your calories or pick sort of healthier choices. For patients with IBM, muscle atrophy can become a problem, and swelling can become a problem. So in those cases, a nutritionist can be helpful to know. What we know is high protein can be good for your muscles, and so you want to make sure you're getting a good amount of protein. Constipation for patients that are in a wheelchair can become a problem, and so it's important to recognize this as part of the syndrome and ask your primary care doctor if you need help with constipation, because remember that our bowels move when we're walking, but if we stop walking, then the bowels slow down. And it's not because necessarily the muscle is affecting the bowel, but it's sort of secondary to the muscle weakness that's happening. And then we have a social worker in our clinic. I find her invaluable. She has a number of resources that she hands out to patients, from caregiving to home health services, support groups. I think the TMA is a wonderful resource for support groups and connecting with patients. I think patients sometimes give other patients the best ideas and the best advice. So certainly tapping into that, and like you mentioned, I think having a psychologist or a psychotherapist on board if you don't have an outlet or if you do need someone to talk to is an important part of your care. And then lastly, just a list of other specialists that sometimes you may or may not need. For patients with dermatomyositis, if there is severe skin involvement, I think it's okay to ask for a dermatologist because they sort of have another way of approaching this, and sometimes they can give you topical steroids. They have other ideas that we as neurologists or rheumatologists may not think of. And then there are certain instances where the GI system can get involved. We've seen it in the antisynthetase syndrome and in dermatomyositis, where bowels can actually become involved. And so if you're having severe GI issues, at least once getting a GI consult can be helpful, just to make sure, is this just related to immobility, or is there something else going on that's attacking my bowel? And so if you're lucky enough to be in a center that's close to a myositis center, our approach is we have all of these specialists on board in one clinic day. And that's sometimes the nice thing about going to some of the myositis centers is that in one clinic day, we have the patient see 7 or 8 people. But yeah, the visit may take 2 or 3 hours, but then the patient doesn't have to worry, do I need this person or do I need that person? But if you're not close by center, I think, you know, some of the most important people to start with is having a good rheumatologist or neurologist, your primary care doctor, a physical therapist. I think everyone should have seen at least once early on in their disease to give you some guidance, and then a check-in, you know, once a year even if it's possible, and your insurance allows. Everyone at some point should at least have a pulmonary function test. If you have long-standing IBM, you should at least have it once because you want to know, sometimes the diaphragm may not be so involved, sometimes it's pretty involved. And one of the leading causes of fatigue in IBM is because you needed BiPAP to help you with air exchange at nighttime. BiPAP's a form of CPAP. You've heard of people with sleep apnea use CPAP. Or BiPAP sometimes is helpful for people with diaphragm muscle. But I've had dermatomyositis patients that required it, some of the antisynthetase that required it. And then your dietitian, and we have a really great medical assistant that we've put in charge of patient care and sort of a continuity for patients to contact. So, but I think as long as you know about the right questions to ask, you can be empowered and be in charge of your own care when you're out in the community.
Have you had other doctors call you for?
Yeah. Because we're all listed on the TMA, we have either patients email us or even other physicians just saying, I'm not really sure what this IBM thing is. And so, well, my patient needs knee surgery. Is that safe or not? And so a lot of times we see patients even for a one-time evaluation just to sort of characterize their disease, understand it, let them understand it, and then give back recommendations to the community. So one thing, if you do live far away from a myositis established center, is you could just come in for sort of a one-time consultation and ask, Doc, can you just send a letter to my local neurologist so that way they have some recommendations for the year. I actually have an IBM patient who I used to follow in Boston, but I'm in California, and once a year he still flies out to me because he just wants to see, he says he knows that I understand his disease, right. So he wants to do that once a year checkup.
Sure.
And so I think these days it is sort of feasible. The Myositis Association has done a nice job of identifying people around the nation where if you're not feeling comfortable with your care, I think it's okay to ask for an opinion once at a center and make sure some of these checklist items that I talked about are involved in your care.
With vaccinations, you said it should be a monovirus. Do you know the blue shingles vaccinations in 2 parts? Is that a monovirus?
I don't want to say off the top of my head that it's 100% okay. I feel like every few years they're changing some form of it, but I just tell my patients to simply ask, is it a live vaccine? Because it'll say it actually on the vial itself.
Oh, when you go to the pharmacy.
Yeah,
okay.
And so a lot of times they'll know. The person giving you the injection would know right off the bat. So I think it's just a simple question. Because things are constantly changing in medicine, what was true even a few years ago may not be true now.
So is that if you're on immunosuppressant therapy, or does it matter if you're not?
The live vaccine only matters if you're on immunosuppressant therapy. But in general, having myositis, you should make sure you're getting your flu shot and your annual vaccines. I think that's very important because you may have a lower threshold to developing a pneumonia if you're already weak, right? So, but the live vaccine is only for immune sequences.
Do you have where we could see or tell me where I can go find one, but you mentioned that myositis panel. What all are all the tests that are within that panel?
Okay, let me show you this slide if you want to take a picture of it. That's generally, these antibodies, Dermato and Antisynthetase, are generally in the myositis panel. And then if you're concerned about statin-related myositis, that's a separate antibody. And then for IBM, that's a separate antibody. A lot of the panels previously were originally done, many of them at WashU in St. Louis. So we have continued to send our blood there, but the Mayo Clinic does it. RDL is a local lab that will send it to Mayo oftentimes. So as long as you ask for the myositis panel, it's a very simple test that any primary care physician, if they Googled it, I think even, would be able to find it.
Do you have a card for it?
I don't have a card on me, but I'm listed in the booklet.
Oh, okay.
And my name is there. And then in the back of the booklet, all the medical advisory board physicians are actually listed on it. We're also listed on the Myositis Association website. So, and I believe our email address is on there because I do get emails from patients around the world that just have questions about myositis.
Are you familiar with the high altitude training mask that runners use?
No.
The runners use them to develop their lungs.
Okay.
For changes in altitude. And I'm wondering if you could use one just in your living room as a way to expand and exercise your lungs. I'm just wondering if that could be a multi-use thing. I'm not saying go out for people to go out and start running with these things, but I happen to have one and I've used it in the past.
It's called a
high altitude training mask.
Okay, I'm going to have to look at
You'll
that.
probably see them advertised in sports places like Academy Sports or Dick's Sports.
It's a restricted breathing mask.
Yeah, it's a restricted breathing mask.
You use it before you dive or you run. I live at altitude anyway,
I
so
see.
I'm tired all the time anyway.
Well, I do want to clarify, there's different, so if you have dermatomyositis, then the underlying condition affecting the lungs may be interstitial lung disease, which actually affects the lungs. But in the inclusion body myositis, technically there's not any lung problem. The weakness is the diaphragm underneath the lungs being weak. And so it's not necessarily a problem of oxygenation. I don't know what this altitude mask does, but it's not a problem with oxygenation in IBM. It's just a problem with air exchange at nighttime because when you're in the supine position, your diaphragm has to work harder. But if it's weak, it's not going to be able to push out the carbon dioxide that it's trying to at night. So you end up retaining carbon dioxide at nighttime if the diaphragm is weak, and that can cause fatigue. So some of the symptoms can be fatigue, feeling restless, morning headaches, but the only reason I mention that is because it's not, in IBM, it's not a lung problem. It's a diaphragm muscle problem. But in dermatomyositis.
Which I'm dermatomyositis.
Oh, okay.
So
okay.
I didn't know.
But I'm going to have to look at that. You're the first person.
I just wonder if that would be a viable.
Have you tried it?
I'm sorry?
Have you tried it?
Yes, I use it once in a while, but as a, to use it therapeutically, I'm not sure if it's doing if it would help my situation.
Yeah, I'll have to ask our pulmonologist or respiratory therapist.
And you can I know a lot of sporting goods stores show them, and if you see somebody running down the road, it looks like they're a monster or something. They painted some up to have crazy looking, you know, faces on them. So some people, that athletes that run with them, have, you know, that look kind of crazy, but that's what it is.
I see.
I've been diagnosed with poly for 24 years. So from the very beginning, it was very limited as to what we knew.
Yeah.
So now you talk about the muscle MRI, which I'm assuming that if somebody is newly diagnosed with something now, that having that as a baseline, and then you look at it later, would it be okay for me to have it now and still keep, you know, checking on it, or?
So I always have two questions when someone tells me they have polymyositis. One, when you were given steroids or immune treatment, did you do really well and like get back to normal?
It took a long time, and then other treatments, you know, different cyclosporines, IVIG, all of that. But then for the last 5 years, it was with methotrexate.
I see.
And did very well, but now it's affected my liver. And so we've gone up again with the steroids and now down. And so, but knowing all of this new thing with all the antibodies, I don't think anybody was aware of that.
Yeah, I mean, more than the muscle MRI, so there's a couple elements to that, but one, if you haven't had your antibodies checked, I would ask for that, because you can get insight into which particular subtype you have almost, and what the prognosis may or may not be. And then number two, majority of people are still not using muscle MRI for diagnostic or evaluating purposes. However, some of us on the medical advisory board have found it very helpful. And in our clinic, we do it pretty often for a few things. One, sometimes if I'm putting someone on immune treatment, I do it before to see the degree of edema in the muscle. Edema indicates active disease. And oftentimes when people respond well to immunotherapy, they have done studies on muscle MRIs in patients after treatment, and you'll see that the edema all either resolves or is very faint. So for some of my patients that I do have on immunotherapy, I do check it pre and post, sometimes 6 months or a year apart, to see if the edema has resolved. I don't do that for my IBM patients because it's not something I'm chasing.
Yeah, well, then the blood levels will all indicate, yes, your disease is, you know, at a level that's safe, whatever.
Yeah.
But because the legs still hurt, there's so much pain.
Oh, okay.
You wonder what's going on there.
Yeah, so pain is a really interesting symptom. You know, you can develop pain. And so pain can sometimes happen from the myositis itself. And so if you do like a thigh muscle MRI and you see striking edema there, you may say, oh, well, maybe some of that pain is because of the active myositis. However, if there's no edema there, and it's maybe some muscle atrophy, which you can also see on the muscle MRI, you might say, is it more joint pain or just from, you know, not being able to ambulate or exercise like you typically do? So I find it helpful. Not everyone is at that status yet. It's certainly more at an academic level that we are doing muscle MRIs. I certainly, I think the antibodies testing will be easier to convince a local neurologist and primary care doctor to do than a muscle MRI.
I'm going to try and get, I think, referred to Rochester. We're close to that area.
Oh, okay.
So that would be, if that would happen.
Yeah, but I think antibody testing is very easy to be done now that it's commercially available.
With IBM patients, are there certain exercises you can do, or is this exercises in general?
I think a great, without, you know, of course, examining a person, having a physical therapist who sort of understands muscle weakness, they can cater your exercises to the degree of muscle weakness that you have. What's unique about IBM is sometimes patients can have a very mild form of the remission, and some patients can have a pretty severe degree of atrophy and weakness. So I think it depends on where your level of function it is.
Can you get that through blood tests?
No. The level of, yeah, because the CK level actually initially in IBM can be high, but over time can normalize and even be normal. And it doesn't tell you that just because your CK is normal, you're now normal.
Yeah, hers is in pretty good shape.
Yeah, and sometimes in IBM the CK never goes up. So that can be variable too. But I think, I do think stationary cycling is sort of an easy way of me of telling everyone without being able to examine each one of you individually, that it's certainly a safe form of exercise.
We have an aerodyne where you pedal and do this.
I think that's great, because that's where the upper body involvement happens too. We know grip in IBM gets affected, upper arm muscles can get affected. I do think it's important to follow the rule of the no pain, no gain motto doesn't apply. And so if you're exercising 15 minutes and you say, I got this, you know, tomorrow I'm doing an hour, and then the next day you're wiped out, you got to listen to your body. So I think that's really important.
But exercise is a good thing to at least keep the good muscles going.
Yeah. We do know, I think the belief previously used to be that in the acute setting, like, don't do anything, let's just treat you. But what we've learned is that some form of exercise is good even early on, and certainly later on too. Oh, sorry.
Do you actually, do you see patients yourself, or?
Yeah. I'm the director, but I'm also seeing patients.
She sees him.
Yeah, I love seeing patients. I think it's really, no matter how much research I'll do, I'll always be seeing patients.
You're very informative.
Oh, thank you. Thank you. It's a passion of mine. We have a senior colleague who's retired 3 times, and he's in his 80s. And I tell him I want to be just like him when I grow up. So yeah, no, I enjoy seeing patients.
I was just saying, one of the ladies that does the exercise class had done a study on the condition of creatine. If you were supplementing creatine, I just want if you would comment.
Yeah, no, I think what we understand about creatine is that we think it's safe. I never want anyone swallowing the whole bottle of supplements. I mean, we do sometimes see these extreme athletes. I don't know if you remember, maybe 5-10 years ago on the news, there were some athletes that were just taking large bottles of creatine, and it can damage your kidneys and, you know, cause. But whatever the GNC recommendation or supplement is, creatine helps with protein. Protein helps with muscle mass.
You
so
recommend that?
we think it's fine to use for people that want to try it. We don't have great data saying that, yes, that's the cure and treatment, but we think it's a fine supplement to use.
How would you recommend?
I usually tell people, if you want to take it, just follow what the bottle says. Because I don't have a particular brand, or I don't have.
I think she did mention that you need to watch about the purification and how pure it is.
Okay.
And some you can buy at Walmart and there are other stores that is not as good as maybe a GNC or something. So you have to look at how pure it is.
Was that the physical therapist on the
Dr. Alexandria.
Oh, Anderson?
Yeah, she's from Sweden.
You have a dietitian on your team. And I have a dietitian. She said not everybody needs the same thing, so they make you do an entire meal tracking plan, and then they go back and do some research. So what I wanted to take, she goes, no, I want you to do these things because you're already getting this stuff. Because if you superload on proteins as well, it's other issues. So
I mean,
they'll tailor it. They're not that expensive
The
as
reason I
sound
haven't
for one meeting.
delved into it too much, I agree, is I'm sort of a well-balanced diet person. I don't believe in cutting out anything, and I also believe in like supplementing your diet with just good natural food. So, but people ask me about creatine all the time, and what I also want to make sure is some supplements can be bad and cause harm, and so I've never seen creatine cause a problem when you at least just take the normal amounts that is what the bottle recommends. But I'm sure Dr. Anderson has a better guidance on like dose and quantity and things.
I'm on CoQ10. What is that?
So coenzyme Q10 is another sort of favorite supplement that people have done. They've done trials. Another disease population I follow is ALS or Lou Gehrig's disease, and those patients also can have a lot of muscle atrophy. So there have been some studies in those patients with coenzyme Q10 that didn't show, well, again, not the cure-all, but certainly didn't show harm, and some patients felt like they were, again, having some buildup of protein and muscle mass. So it's another supplement. I was just going to mention that, thank you. CoQ10 and creatine are my two supplements that I say it's fine to take. It's not something that I constantly recommend because I haven't seen well-published data yet on it, so I'm always careful about extreme supplements, but I haven't seen any harm.
You're going to say there's on California, Boston,
yeah, so many of the people on the medical advisory board actually have centers. So Dr. Mammon, he's at the NIH, there's New York, but they're on the Myositis Association, they actually do a list of patients and centers. So it's a great resource to just check if there's a center nearby you. Where are you at? Oh, okay. Sorry, I thought I saw CA, and I was like, that's California. Oh, okay. Yeah.
Where is that? I didn't hear.
Outside of Atlanta.
Okay. I thought it was Nashville, close to Nashville, Tennessee. I'm trying to find the center that's close.
Yeah.
I think John Hopkins is what, Baltimore?
Yeah, there is that Hopkins. I don't know how far that is from. Yeah.
Mayo has a clinic.
Mayo has a
center.
They do have a center. I'm not sure anyone in particular is specializing in myositis. I know some of the physicians there in Florida specialize in Lou Gehrig's disease, but I'm not sure about myositis at Mayo. Mayo here in Rochester, in Minnesota, does, and then Hopkins definitely has a wonderful myositis center. So, like I said, the other thing that can be done is one consultation at least, just to make sure, is my diagnosis correct? Is my management appropriate? The nice thing about the people that I put on immunotherapy, it's usually medications that I like to see. They sometimes, especially the other immunosuppressants like methotrexate or azathioprine, they can take a lot longer to work. So they're not medications that I'm changing on a monthly basis. I want to give it time, like 6 months or a year. So sometimes if you go to an academic center, if you feel like you need more insight, they can give you sort of a 6-month, 1-year plan.
Would you talk to our doctors if we recommended them call you? Because you're really informative. A lot more.
Thank you. Thank you. I am happy to, feel free to grab me. I'm here the next day too. Yeah, emailing's fine. If you see me, please feel free to chat.
Myositis Association, helping patients become peers now for the past 25 years. So if you have been diagnosed, here's an organization to unite us. 8,000 members they can boast. For that real strange word that no one's heard, it's myositis. There's an annual patient conference which is just second to none, where you'll learn a lot and network, and you'll also have some fun. And their website is updated with a lot of current news, with lots of info and resources, and much more that you can use, like info TMA compiles, and like lists of clinical trials, and lists of research too you can review, cause it's all there for you. So hooray for the group TMA. It's the Myositis Association, helping patients become peers now for the past 25 years. So if you have been diagnosed, here's an organization to unite us. A quarter century they can boast. They've been the group that's got the scoop on myositis.